And for society in general, there's still a common notion that things should be put in people's mouths so they won't swallow their tongue. But of course, you realize your tongue's attached in your mouth, so you couldn't actually swallow it. I think what people actually mean by that is the tongue occludes their airway. So what do you do if the airway gets occluded? It's simply the same thing you do for any other first aid. Just pull the jaw forward, and that'll open up the airway. Fortunately, during seizures, it's extremely uncommon for someone to obstruct their airway, particularly if they're laying on their side. What about drug treatment during a seizure? That is, let's think back to that situation where a seizure starts and then does go on for 5 minutes and doesn't stop, or there are recurrent seizures. Well, of course, the objective is to stop the seizure, and that means you have to give something while the child is still seizing or right after it's done to prevent the next seizure. That is to abort, let's say, a seizure in a cluster of seizures. Obviously, if they're still sleepy, as they often would be after a tonic-clonic seizure, then you can't give them something by mouth, can't give it orally. And particularly if they're still seizing, you can't, because they just aspirate it instead of swallow it. So there aren't very many other routes available right now. The most common alternative route is rectally, and the most common thing is to give rectal diazepam. There are many studies about nasal or inhalation or even injection forms of medications that are in development, but those are not available now and probably won't be for years. So rectal diazepam is the most commonly administered drug to abort or stop seizures or prevent their recurrence. The brand name of this is Diastat, and it's given at 5 to 20 milligrams in a single dose, depending on the size and age of the person. It's given in a syringe without a needle, because it's placed in the rectum. It's a gel that's injected into the rectum and is absorbed through the rectal mucosa more rapidly than if it would be given in other routes, and that's the reason for rectal administration. It acts in about 5 to 15 minutes. It very rarely causes excessive sleepiness, so that afterwards the person could be more sleepy. There's even lower risk of respiratory arrest, so that you might be concerned by giving rectal diazepam someone might have decreased respirations or trouble breathing. But in fact, in randomized controlled trials, people who got placebo instead of rectal diazepam actually had more respiratory problems from their seizures than did those people that got diazepam. So I think everyone can feel very comfortable getting rectal diazepam for people that need it. What about giving other anti-epileptic drugs or AEDs during school hours? Well, this is a little different issue for these kind of medications than it is for medications for asthma or something like that. The timing of anti-epileptic drugs is very important, and consequently you may not be able to avoid giving it during school hours. Of course, it would be best to give it before and after school, but in some cases it has to be given during school hours. In this case, consistency is the biggest problem, because although most days of the year kids do most things the same way each day, there are always exceptions. And consequently, there really needs to be a system in place so that the child, the nurses, the teachers, the office staff, the administrators, everybody knows the routine, and that way if one person is gone, the routine still happens. It's also important for the child, if they're able to take responsibility for taking the medication. This might mean setting an alarm, for instance, or scheduling it between specific classes, so every day between third and fourth period, the child knows to go to the office to take the medication, for instance, or with lunch or recess. Another way, particularly for smaller kids, is to use a chart. As you can imagine, they might be excited to put a star on the chart every day that they're able to take the medication. Another medicine-related issue that nurses commonly encounter in schools is, do anti-epileptic drugs affect a child's academic performance? And the answer is, sometimes. The goal of epilepsy treatment is no seizures and no side effects. That's the unequivocal goal. However, sleepiness, fatigue, and poor school performance can be signs of medication effects that children can suffer. An important way to distinguish whether or not those problems are due to the medication from whether or not they're due to other things in life, because after all, there are many children that have sleepiness, fatigue, and poor school performance who are not taking anti-epileptic drugs. So how do we distinguish whether the medication is responsible? Well, really it's the timing with increasing doses, and this is a place where the school nurse and the school personnel can be very helpful to the parents in understanding, was there an increase or the occurrence of these kind of problems after starting the medication or after increasing the dose? If so, it may very well be due to the medications. But if these problems predate, if these symptoms predate the drug use, then of course they're not due to the drug. So someone who's always been sleepy or fatigued or had poor school performance that starts on a drug and continues to have that, we can't really blame it on the drug. So it's important to recognize where the symptoms occur in the course of drug administration. So in summary, we've talked about the classification of seizures really just as a model if you understand the variety of types of seizures that occur and the context they occur in. We've talked about how to recognize a seizure then, as well as different types of seizure. We've talked about acute first aid administration of a generalized tonic-clonic seizure. We've talked about administering drugs in school, particularly diastat, to abort seizures or to prevent clusters of seizures. And we've talked about anti-epileptic drug use in seizures.
This girl is having an absence seizure.
Sabrina, talk to me.
What? I'm fine. I always tell my mother this. I'm fine.
In an absence seizure, generally the concept is that they're disconnected for a few moments. They're very likely to pick up exactly where they left off, but generally speaking, they do not know what is happening in that 3, 4, 5 second period of time.
This girl also has absence seizures, and you will see her have one as she's talking.
They take back that statement because he can be as heavy as ever.
Then there's a real blankness, a vacant look in the eye, and then all of a sudden they're right back with you and able to engage.
Oh, pardon?
This young man is having a complex partial seizure, and his consciousness is impaired. These seizures are the most common form of epilepsy in teenagers and adults.
You want me to call him like I usually do? To get his attention. Kevin? Kevin?
I believe it's important for teachers to be aware of what happens when a student has a seizure, and to also be cautioned against jumping to conclusions that the student's behavior may be drug-induced or may be caused by lack of interest in class.
Kevin? 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 Can you hear me? Can you hear me?
Complex partial seizures may create a variety of automatic movements or behaviors, such as this young woman is having. She cannot control these movements, nor is she aware of them. The movements of her hands are automatic. They look like deliberate movements, but they're not. They're part of the seizure. Her awareness of her surroundings is clouded. The seizures most people think of when they hear the word epilepsy are generalized tonic-clonic seizures. The tonic phase is the stiffening of the muscles. Then the jerking movements begin, the clonic activity that you see here. It happened to Russ Burkhart in class.
Mr. Ehrenberger, my science teacher, was explaining something, and right down to the very last second, I remember everything, and then I just blacked out, which I thought I did.
And all of a sudden, I was up in the front of the room and crashed to the back of the room and looked back, and Russ was on the floor. He was in a full seizure when I got back to him.
Tonic-clonic seizures rarely last more than a few minutes. A person having one isn't conscious and won't remember what happened. The skin may become pale. Breathing may seem shallow and labored. Sometimes a teenager may lose bladder or bowel control or vomit as the seizure ends. These seizures may look painful or even life-threatening, but they're not. They end naturally after a minute or two.
Joanna Collins is a school nurse at Henrico County Schools, Regional Director for the Virginia Association of School Nurses, full-time student in the RN to BSN program at James Madison University, and mother of a child with epilepsy.
So one of the things that we want to talk about is the health care plan, which is a pivotal part of the school nursing function. We write health care plans for our students with chronic conditions, epilepsy being one of them. So with that, we want to make sure that you have an accurate history from the parents and appropriate medical orders from the physician, and that the health care plan is really just that. It's medical management. Now, you can always reference the CD-ROM that you're going to be receiving, and it has an Epilepsy Foundation generic healthcare letters, action plans, doctor's orders, those types of information. There's lots of wonderful information on the CD, so you want to make sure that you have an opportunity to kind of peruse the information that's on that CD whenever you get a chance. So with your healthcare plan, you want to make sure that you have your emergency first aid, what types of medications, whether they're taking oral or rectal medications, if they have a vagal nerve stimulator, how to actually operate a vagal nerve stimulator to help stop a seizure log so that you can monitor their seizure activity during the school day, which is extremely helpful for the parent when they go back to their follow-up appointments to be able to say, yes, my child is having seizures during the day. This is what they're looking like. This is how long they're lasting, so that they can do some medication adjustment, those types of things. Brainstorm with the teachers, with the students and the parents. Get with them and think about the things that they're going to be needing in the classroom, because you need to get with the parents and you need to get with the teachers and be able to give them the information that they need to be able to educate these students in the classroom in the least restrictive environment possible. With small children, you want to make sure that you're not only educating the child, but also the classmates and their teachers that may be fearful or scared of a seizure, that they're okay and they're not going to catch their epilepsy or anything like that. Things that you can use to help them would be present the teacher with some coloring pages or maybe a puppet show. The Epilepsy Foundation of Virginia can come in and do a puppet show for you. There's some wonderful resources out there. Make sure that those resources are made available to the teachers so that they can help those young children to understand that the student is okay and that when they have a seizure that they'll be taken care of. Also talking to those young children who may not understand what exactly is going on with their bodies and making them feel comfortable in the classroom and outside of the classroom, and then transitioning back to the classroom, helping the teachers to understand that, you know, there's still good learning going on even though the child has epilepsy and that they're in the classroom environment. Preteens are an interesting little group of people because they're worried about puberty and their bodies changing and social events and those types of things, that you add epilepsy into the mix and they get very concerned that they're different. And that's a big thing, especially in middle school years, of being different. They don't want to be different. They want to be like everybody else. A child has a seizure and now maybe you have to administer Diastat, and they need to have a quiet place that's private so that other students aren't around. You don't want the principal come rolling up in there, especially if he's a male. That may make your female students feel very uncomfortable. But at the same time, you need to talk to those kids and go, you know, it's the people that are taking care of you and that they're trustworthy, and letting them know that you're there to talk about not only their epilepsy and their seizure disorder, but also their concerns. The school nurse is going to be the best friend for the student with epilepsy from the time they hit pre-kindergarten all the way up through their high school years, and helping them plan and look forward to the future and knowing that they're going to be okay and that they're going to be okay with their body. They may have a chronic condition that needs to be managed, no different than a child with diabetes or a child with hemophilia needs to be managed. They're just another child that's going to do okay. And helping them talk through their concerns. Also have to worry about their bodies changing, that their levels of hormones are getting off whack, so they may have an increase in seizures, they may have a decrease in seizures, and making sure that you're talking with the parents and letting them know. As we talk about teenagers, adolescents are not exempt from teenager problems such as premarital sex and peer pressure and going to parties with friends where they might be tempted to try alcohol or drugs, and talking to them about, you know, the consequences of doing those things. Also, 15 and 6 months hits, and in Virginia, they're eligible for their learner's permit. Well, a child that has had a seizure within the last 6 months is not going to be able to drive, and that's going to be a big concern, not only emotionally for them, that they're going to have to catch a ride everywhere and they're not going to have that independence that other children have, but also the fact that, okay, well, what are your other alternatives? Are you going to be able to ride a bike to get where you need to go? Is it walking distance? The things that you're interested in doing, those types of activities, and talking to them and helping them work through those, not necessarily giving them the answers, but helping them work through it. Also noting that birth control isn't as effective when the students are on seizure medications. So that's something that they need to be aware of, and that, you know, not only do they need to be protected from STDs just like any other student that has premarital sex or sex in general, they need to be made aware that there are consequences, there are interactions with taking birth control, and that they need to make sure that they let their healthcare practitioner know that they have epilepsy and what medications they are. So teaching them now that they need to also be their self-advocate. They need to be comfortable talking to their friends about what their seizures look like and what to do in an emergency, and to know that they're going to be okay, but they need to be able to talk about it and be comfortable in their bodies. That's the role of the school nurse. You're an extremely important role. You're an advocate, and you're a partner with the parent and the student and the teachers. And letting them know that is one of the best things that you can do to help the student with epilepsy in school.
Absence seizures usually require no first aid. However, they should be reported if seen for the first time. Any information the student missed should be repeated. Complex partial seizures last only a minute or two, though the teenager may feel confused for a while afterward. It's easy to mistake them for behavior problems. If restrained abruptly, the adolescent may strike out in a reflex action, which may look like fighting. In managing these seizures, it's important to be calm, reassuring, and make sure the student is not in any danger.
Gently directing so that they don't go out the door, down the stairs, somewhere where they could be into trouble. Sometimes all it takes is being smart and closing the door and letting the youngster wander around the classroom. Important probably not to do a lot of direct interaction, because the youngster is confused and may well not understand the good motive.
After the seizure is over, help reorient the student to the classroom. If there's been no history of seizures, it's important to inform the school nurse and the parents.
If he's sitting in a chair, you ease him to the floor so he doesn't fall to the floor. You move objects away from him that may cause him injury or hurt him while he's having a seizure. And then just be very supportive and be calm during the seizure.
Once he's on the floor, turn the student on his side so that saliva runs forward and the airway is kept open. Loosen any clothing that may restrict breathing. Gently cradle his head in your hand, or put something soft, such as a sweater, under his head. Do not hold him down or forcibly restrain him. This can cause injury. A persistent fear with these seizures is that the person will swallow his tongue. This simply is not true. The tongue is attached to the bottom of the mouth and can't be swallowed. Nothing should ever be forced into the mouth. That could break his teeth or cut his mouth. Usually, it's not necessary to call an ambulance for a tonic-clonic seizure, but there are a couple of exceptions.
An ambulance should be called if the seizure lasts for longer than 5 minutes, if the seizure goes from one seizure into another without stopping or without the student regaining consciousness, or if there is no known history of seizures in that particular student.
After a tonic-clonic,